notice our group name, Anesthesia Services of Birmingham, actually been around for a good number of years. So since 1946, the group has been created and centralized in Birmingham. But here, especially in the last 4 or 5 years, we've really expanded, and could not be happier to be here. And in particular, I'm very lucky to be the chairman for our group here. And the relationships that we've built so far in this relatively short period of time have been really spectacular, and y'all should be very, very proud of your medical center here. So anesthesia, it's a very scary thing to a lot of people, okay? So we know this, I know this. Every day, folks come in, they have particular questions, they're very, very anxious, and all that is totally normal. One of the best things about my job is the fact that I know that I can do a good job for you, and I try to let you know how I'm going to do that. Some people want to know more than others. But, we'll talk just a little bit about some of the things we do, maybe make it where you're not quite as fearful, and, really let you know why we like what we're doing and what we're going to do for you. So we'll just kind of go through some things here. Start off with a few pictures just for fun. All right, so what we got here, top left, prior to any type of anesthesia. This guy's getting his leg cut off, he's being held down, okay? But, this really wasn't all that long ago. So less than 200 years, that's really not that long. That's got to be pretty miserable, obviously. Moving on, a few years later, in the 1800s, you had this is the first ether anesthetic. A lot of people have heard of ether. It's been phased out a number of years ago. But what you got here, kind of hard to tell. This gentleman sitting here in the chair, he's kind of sitting down with his head laid over to the side. They had some ether anesthetic applied, and they're cutting this mass off the side of his neck. So the funny thing about this, the reason I add this, is kind of for the things you don't see here. You don't see gowns, drapes, anything to prevent infection. You don't see oxygen on the patient. You don't see anybody monitoring the patient, with any sort of special monitors or anything. This is like, ground zero of everything that came after. But you had to start somewhere, and a lot of it started with experimentation. Lots of different drugs that the folks at the time would experiment on themselves. So there's actually a lot of interesting stories that go along with that, as you may can imagine. Jump forward, and this is kind of our setup. So if you're coming in for a procedure, you're having surgery, we've got a drape up, and back behind that we have all of our stuff. And so basically I kind of think of this as our anesthesia cockpit. So this is all of our instrumentation. You see like a 747 jumbo jet, they've got hundreds of dials and instruments and everything. Ours is kind of similar. We have all of our monitors keeping a close watch on you, all of our, the ventilator, everything to breathe for you, everything we need, all of our drugs to help take good care of you. So it's just kind of it was a pretty quick progression. If you think about it, over the last 100 years or so to get to this point where it's become an extraordinarily safe practice, and really one that's tailored for each patient, for each procedure. So, all right, well, how safe is it? The question we see a lot, and lots of different ways you could kind of address this question depending on what you want to look at. But if you just want to strictly look at death rates, okay, so for every 250,000 accidents that people have at home, there's approximately 22 deaths that occur from that. For car accidents, for every 250,000 car accidents, approximately 41 people will die there. And it's estimated that for 250,000 anesthetics, kind of across the spectrum, for everybody, there would be approximately 1 death. Even that, to me, seems a little high. The reason I say that is that considers kind of everybody. So it considers very, very sick people coming in for emergency surgery. Lots of times that if you strictly want to look at did anesthesia really contribute or cause this death, the number is extraordinarily low. So if you're coming in for a sedation, a colonoscopy, you're otherwise been doing well, I would actually consider that number to be much lower. So have some different ways to look at it, but at least it kind of throws some numbers on it anyway. And the reasons, they're multiple. Why? One, better training. Really, we're just, each year as we move on, there's more and more research done. It's really a lot better training through the process. about anesthesia and how all these drugs interact with everybody and how things change through time. We're trying to keep up each and every day. Better drugs, most certainly, whether it be less allergic reactions or bad reactions to certain drugs over the last certainly 70, 80 years, that's been a big change. And better monitoring, two good examples there. There's been, in the last 40 years, both pulse oximetry, which is if you ever come in and you have the sticker on your finger or on your ear, or even on your forehead sometimes, helps monitor your oxygen level. So 40 years ago, we didn't have that. Obviously, that's been a huge boost in the decrease in risk. And also, there's been another monitor called a capnography, which is basically measuring how well you breathe. So how well you take in oxygen and expel carbon dioxide. We can measure how well you're doing that with that monitor as well. So that's just two examples of some of the improvements that have been made. All right. Anesthesia is kind of encompasses a lot of things. So there's three main types we can kind of break it down into, and so that's one way I thought we could kind of talk about it, just to kind of break it up a little bit. First, we'll talk about general anesthesia, and this is what most people kind of consider when they think about anesthesia. And what that is the breathing tube type of anesthesia. So lots of folks are very, very worried about that. It's a scary thing. It's kind of an unknown thing. You don't know what's going on. You're going to be asleep. You know, it's fear of the unknown, and being anxious about that is absolutely normal. But basically, this is for any kind of procedure where you have to be totally asleep, like anything getting operated on your abdomen, like you're having your gallbladder or appendix out, or hysterectomy, or hernia surgery, things like that. And the reason we have to use these breathing devices is because you're so asleep, you won't be able to protect your own airway and breathe for yourself. So there's a couple different ones here shown on the screen, and basically we're going to use the least invasive one that we can. So we try to keep things as comfortable for you as possible. The horror stories about people being aware about the breathing tube and things like that's extraordinarily rare, and we take great care in certainly ensuring that you're completely unaware about your breathing device, that it's even been placed. Most people don't even realize it years later when they're asked if they had a certain procedure and they weren't sure if they had a breathing tube, but if they tell me what procedure they had, I can ensure that they did. So anyway, that's just kind of the main points about being totally asleep. But let's see, how do you know that I'm asleep? It's a great question. All right, first off, like I keep saying, anxiety about that is totally normal. We have medicines built just for that. When you come tell us that you're very nervous, or it's very obvious when we come see you ahead of time. So first off, we're with you the entire time, and we have someone with you throughout your entire course. So we're not giving you medicines and walking away. We're not focusing on something going on over here. Everything is about you when you come see us. So, but to answer the question, we have multiple ways to determine that you're asleep. And here we're talking about a general anesthetic with the breathing tube type of anesthesia. So physiologic monitoring is just a fancy way of saying we look at things like some of those monitors like blood pressure cuffs, which people hate because they go off every few minutes while you're waiting to go back. But that's something that we're monitoring. So heart rate, blood pressure, things like this we monitor. It seems kind of simple in terms of all the complexity that occurs with anesthesia, but the fact is, if you're totally asleep and having a surgical procedure, your body will still respond to pain. So your heart rate will still go up if you get cut on after you're asleep. So that's, all these types of monitors we're gauging the entire time. It's kind of, you're looking at all the different monitors constantly, checking out what's going on in the surgical field. Everything's tailored to you the whole time. We have an anesthesia depth monitor, which is kind of a more fancy one. So this is something that's hooked up to our anesthesia machine. It's a number that's kind of calculated through the machine using the different anesthesia gases that you're breathing in and out to determine how asleep you are. And this is yet another way where we can help determine that when you wake up, you're not going to be mad at me. So, and there are actually even more ways to determine kind of more complex ways that we can use depending on case to case. All right, so the one that also worries people is when they're coming in for a procedure. It's maybe a little less invasive procedure, but say, well, you're going to get some good sedation for this procedure. And I usually get this look like, sedation? I just want to be totally asleep. I don't want to know a thing. You know, the sedation term seems to bother a lot of folks. So let's talk about that a little bit. Most of the cases like this, in terms of numbers, would be things like if you're coming in for a colonoscopy or endoscopy, or smaller procedures, say you're having a finger surgery or having some something removed off your skin. You know, some of these smaller superficial surgical procedures, we're going to be providing what's called a monitored anesthesia care and providing medicines through the IV to keep you comfortable. And you may have heard about some of these, which we'll talk about in a little bit. I get a lot of questions about this propofol stuff. Is it safe? I heard about it in the news. We'll talk about that in just a minute. But we have basically several other medicines that we can use in combination to make sure you're very, very comfortable. And these drugs are very good and very safe. This is not the same sedation that was used years ago. So when folks come to me and they say, well, I had a procedure 20 years ago, or my family member or a friend did, and they did very poorly. They woke up in the middle of it, and the surgeon had to tell the anesthesia doctor to give them more medicine and put them back to sleep. And you hear some things like that occasionally, or you hear about something on social media or some news broadcast or a movie that comes out, and it's really shown in a negative light. This is not the sedation we're talking about. This combination of medicines that we use for these types of procedures is very, very good at keeping you absolutely comfortable and unaware about what's going on during your procedure. The incidence of awareness, which is what everybody worries about, knowing what's going on during your procedure, is extraordinarily rare in something like this. But each one of these techniques is tailored to you. So depending on your medical history, what procedure you're having, all these different factors, what kind of procedures you've had in the past and how well you've done with it. If you tell me you've done poorly in the past, I'm going to ask you about it. I'm going to see what was going on with you, trying to get some more details. Because each time I'm going to make a plan for you, for that day, for that procedure, to make it as comfortable for you as I would my own brother if he came in for a procedure. So that is how I approach the sedation. So this propofol stuff, all right? Everybody's heard about it. Everybody comes in for the colonoscopy and says, all right, I tell them, you're going to get the best stuff we got. And they said, oh, the Michael Jackson stuff, yes. But some people are kind of worried about it. They're like, what was the deal with that anyway? So we'll do story time. So what happened with this, obviously a very unfortunate story, but he was using a massive amount of different types of medicines to help him sleep. Of course, he had a physician that he had hired to administer all these medicines. So on the night of his death, he was being treated about every hour or so with these heavy-duty benzodiazepine drugs, which one dose of which would knock me flat and have me out for a couple of hours. But he had built up such a tolerance, because this was used over time and time again, that he was receiving these drugs over and over and over again. So an hour later, I can't sleep, can you give me more? I can't sleep, can you give me more? So he was given all these drugs, not propofol, but some of these other medicines that basically started to build up in his body. It wasn't working. So this is probably, this has gone on all night, and he's miserable, the doctor's miserable. I'm sure this had happened all the time, kind of hearing how things went down with the story. But he said and Michael Jackson was familiar with the propofol, and he knew what it was and what it did, and he actually asked for it by name at that point, and he was administered what it was actually quite a small dose at that point of propofol to help him finally sleep. He was given it, and for whatever reason, the physician left the room. I don't think it was much more than a minute or so, according to the sources I've read. Came back and he wasn't breathing anymore, and they were unable to get him back. So really what happened there, what it shows is that all these medicines together have a big effect. So if he had received just the propofol by itself, without anything else, it wouldn't have been the same effect. And I only say that to say, number one, just tell you what actually happened. Two, kind of let you know that obviously, because this was not supposed to be used outside of the hospital setting, and it's not just used throughout the hospital. We only use this medicine in the operating room or the ICU. I mean, this is actually absolutely incredible that it was ever used for something like this anyway. But this is actually a fantastic drug that treats people very good. It's the one that folks wake up very, very nicely on. Works very quickly, does exactly what it needs to do. We can titrate it or measure it, the amount we need to give you very easily depending on your height, weight, medical history, age, etc. I mean, everything. We're always adjusting that. Very versatile, can use it for lots of different cases, and it's very, very safe in our hands. So that's kind of what happened there. All right, so we've gone through a little bit about a couple different types of anesthesia general, and then the sedation, and then there's a third main type called regional anesthesia. So this can be combined with other types. So if, say, for example, if you're coming in for shoulder surgery, you're going to have your rotator cuff repaired. You come in, you're going to be asleep for your procedure, but we can use regional anesthesia to provide a pain block to help numb that arm, numb that shoulder up, where your experience will be much, much more pleasant, especially during that day. So regional anesthesia encompasses the epidural and spinal blocks, and also all these blocks for post-operative pain, like for shoulder surgery, knee replacement, etc. So all these different types of orthopedic procedures. And so this is the part I like, okay? So I actually have a special interest in regional anesthesia. I started doing anesthesia, one, because I like meeting a lot of patients kind of at their most critical time. It's really a great experience for me, but also because I like to do things with my hands. So regional anesthesia, I get to go around and do things. So, provide pain relief, things that I can see the results of very quickly. So when I see you in the recovery room and you're, snoozing and waking up really nice, then I feel like we've done a good job for you. That makes my job experience much, much more pleasant. And that's really what I enjoy going to work to do. So I'll talk a little bit about some of the newer things that we're doing there. On the bottom here, we can actually now provide blocks for postoperative pain for abdominal procedures. So this is actually a fairly new thing, and one that we brought to Coosa Valley Medical Center as our group. Within our group, we've only started doing these blocks in the last few years. We've had tremendous success with them on helping reduce patient discomfort for almost any type of abdominal procedure that we do in the operating room. Most of these we can do these blocks for. And I'll just talk about it a little bit because I find it pretty interesting. So what we're talking about here, say you're going to have your gallbladder taken out. You're going to come in, everything's going to go like it usually will. You're going to be totally asleep. We do these types of blocks after you're totally asleep. And the reason it's coming along in the last few years is because of kind of the advent or increase in the use of ultrasound. That we can scan with an ultrasound machine. We do it for shoulder blocks, we do it for leg blocks, and now we can do it for abdominal blocks. And so what we do, we have you totally asleep. We use an ultrasound machine you can feel the edge of your rib, and then down at your hip bone, there's a little gap there, and we can put the ultrasound probe right there and take a look in, and this is what we see. Everybody has 3 muscle layers that run right in this area right here. And what we're going to do, the nerves that are going to be hurting when they get cut on of your abdomen come around from your spine and wrap around and kind of spread out like fingers right here. And what happens is as they come by, what we're going to do, we're going to try and catch them right here and put medicine on them where it'll spread really, really nice and get them good and numbed up. And it spreads a little bit differently on everybody. So sometimes it may help a little, sometimes it may help a whole lot more. It kind of depends. We try to add as much as we can, certainly. But really, and these are really fun. I'm sorry. So we'll come in with a small needle after your sleep, and then put it in between. There's layer 1, layer 2, layer 3, and we'll put it right in there. And when because that's right where the nerves run. We know it runs right up under that second muscle layer. So when we do that and see the picture where it'll spread real nice for us and right under the ultrasound because we can see everything, then we know we have a even better chance of having you comfortable when you're waking up. So the reasons for this, well, there are multiple. So if we can reduce the amount of narcotics that we have to give you, those heavy-hitting IV medicines like morphine and Dilaudid, a lot of people don't do well with them. In fact, some people do very, very poorly when they have to receive a lot of these. It kind of knocks you out. It's going to keep you sleepy. It's going to make you sick. So we try to reduce that as much as we can. We're not withholding it from you if you need it in recovery. Okay, that's not the point. The point is to try and keep things as comfortable for you and reduce the incidence of you being sick from it, and also kind of make where your recovery is much easier and much quicker. Okay, the whole goal here, and really in the last few years, is really kicked up a notch. Especially, our whole focus as a group is increasing your patient satisfaction. That's kind of something that was touched on about, for hospitals as well. We're really kind of focused on much more on the patient as years have gone by here, especially recently. That's become very important. It makes total sense. I totally agree with it. And that's kind of the focus for us, is always your patient satisfaction. Because if you're mad at me afterwards, that probably means that, your satisfaction score is not going to be that high, and was there something I could have done better? So number one, safety and the satisfaction and comfort, I think they all kind of go together, at least from my perspective. So that's kind of just looking at a few aspects of anesthesia, just kind of maybe give you a little bit of information and make it hopefully where it's not quite as mysterious and scary. It's just, at least it's something that you might see on Dateline NBC or something, a scary story that really, I just want you, if nothing else, just remember that when you come to see us, that all the folks from your anesthesia team that you meet, they're focused on you for your procedure. We're taking into account everything you tell us ahead of time. That's why we ask you all these 100 questions ahead of time, because we want to get to know you as best as we can within the 10-15 minutes that we meet you ahead of time. So when we talk to you on the other end, that you had a pleasant experience, and like I said, we treat you like we would our own family member. That's kind of the approach that we take. So there's some smiling faces that you'll see from some of our staff over at Coosa Valley Medical Center, and also some of the folks there. Those at a chili cook-off not too long ago. We'd like to get out and do some community things as well. But I will just say again that our group, Anesthesia Services, has been absolutely pleased, and I've been especially lucky to be associated with Coosa Valley Medical Center. And it's my pleasure being here today and being with all of you.
All right. I know y'all got questions. Dr. Babish, you're not off the hook yet.
Bring it on.
If you take blood thinners and you had an emergency surgery, how are you considered? I mean, what do you do?
That's a great question. That's a great question. It's going to depend on the procedure. It's going to depend on which blood thinner it is. So Xarelto. So obviously there's a whole long list now that I'll always have to make sure that I keep up with. Some of the medicines are reversible. Some of them aren't. And probably most cases in a very short period of time, if you're coming in for something we got to get done immediately, we will deal with it in other ways. Like we won't be able to reverse the effects of the blood thinner. If it's a big procedure, that's what kind of depends on the procedure. If it's a big procedure, probably your chance of needing a blood products would go up a little bit. But that's something that we would kind of have to take on a case-to-case basis. Obviously, that's a great question also, because that's one thing that lots of folks, ahead of time when we talk to you preoperatively, that we kind of have to make sure that we get all those blood thinners straight, especially depending on if you're having a more invasive procedure, because sometimes they're held, sometimes they're not. Just kind of depends, because you're taking it for a reason too. So we don't want to hold it if it'd be better for you to keep taking it. So I just always kind of reiterate, double check with your surgeon, or if you come in for your pre-op visit, what the plan. Got to have a good plan in place there. But yeah, you're absolutely right. It's different if it's an emergency.
All right, hold on, and let me kind of get through there so everybody can hear.
This is kind of I guess, a more complex question, which is that how are they discovering, or what are they discovering and how, about people's individual reactions to medication, specifically anesthesia, but in general, sedative medications, and how you perceive that there's going to be a chance in the future that there will be some kind of test you'll be able to give somebody that will tell you what kinds of drugs they might have poor reactions to, even before you might give them?
That's an excellent question. So first, as far as right now, there's no specific test as far as, if we give certain medications, which one will do better for you. That's more based on less specific questions, but more kind of your history and maybe what medications that your body's used to. It's kind of a lot of what we go along there. But to answer kind of the second part, I imagine that, yes, in the future, probably a good number of years, just based on how complex everything is, as much research as there is going into different types of pain receptors for everyone, that different people have different genetics on these pain receptors, and some people, yes, they do respond better to one than the other. That will still be a number of years before they can kind of pan that out, but I imagine it'll be along the same line where they'll be able to kind of sequence everything in your gene to tell you, hey, take this medicine early for your heart because you're going to be prone to this disease. It's going to be further on down the line, but I bet there probably will be in the future. Yeah.
Okay, other questions? Okay.
I would think many of us here would like to know something about the long-term effects, especially for senior citizens, with anesthesia services. How much risk is involved? I got a shoulder surgery, and I guess the colonoscopy within 2 years. Mm-hmm. So how concerned should I be?
I would say if you're planning on having routine type procedures, several over, a couple of years, your concern level as far as strictly due to the anesthesia should be very low. Those are procedures that individually are very safe. So even if you have to have a few procedures, even in a short period of time, your risk level is not really increasing significantly. Each time, again, taking kind of an individual basis and depending on what's going on. But, unless you tell me unless you start to have problems with certain medicines or a certain procedure, things at that point can probably be adjusted to keep your risk level hopefully just as safe as it would be otherwise. A lot of this just depends on, any changes that have occurred recently or how well you've been doing otherwise will help determine how safely we can get it done.
Basically, I was interested in the psychological effect or mental effect of senior citizens.
Mm-hmm.
There'll be senior moments.
There are, that's a great question. Yes, there are certain medications that can kind of hang on to. Some of these sedative medications can maybe make